For this week's lecture, we are going to cover the topic of alcohol and drugs, health and disability. And while they are all independent subgenres or subfields of sociology, I like to include them together in some capacity because of how important it is to differentiate them, but also because of the historical aspects of them being put together within a sociology of health or sociology of medicine. It is crucial that we differentiate them, but we also recognize how much they intersect within each other and how different people experience these systems to navigate together. So we're going to go ahead and get started. Right away, I'm going to tell you that the first code word is book. The first code word is book. Okay, so the purpose of this lecture is I'm going to cover kind of some theoretical explanations and foundations. You have the materials and the readings to kind of supplement with um, the like statistics and different facts. But I want to cover some kind of theoretical explanations and foundational concepts related to alcohol and drugs, health and disability, and how to explain them from a critical perspective. And again, really one of the crucial elements of this is going to be to help differentiate them and how and why we need to differentiate them, but then also why we need to explore them in a way together. So when it comes to the sociology of health is just kind of an overarching umbrella that encompasses what it means to be healthy, what health looks like. And it is important when we're talking about that, that we recognize the kind of different definitions of health and what those look like across different groups and on a global scale. Um, the sociology of health contributes to, again, just kind of an overarching theme of health, but also illness, and it looks at the intersection between individuals, groups, and larger institutions and structures. It can push us also to kind of think about what we believe about health. So, what are the scientific definitions? For instance, like parameters when you get your blood work, for instance, right? And what it means to be have like a healthy blood sugar level or healthy cholesterol, right? So you have your scientific definitions, but then there's also the element of our societal expectations, perspectives, and our own individual range and parameters as well. So, for example, some people may actually, even though there's those scientific ranges, right? Some people may have a natural range that's a little different. And a lot of doctors will tell you that. So, when we look at these elements, we have to kind of think about the overall kind of complications of what it means to be human, and how the parameters are just parameters, but there's a lot of factors like physiological, sociological, psychological that go together to understand what it means to be healthy or what it means to analyze our society's health. And that's why we also are going to be looking again at this differentiation. Sociology of health is where we would look at, well, first, like I said, historically, alcohol and drugs, disability always kind of are under a sociology of medicine and health. But we do need to differentiate them because there's a lot of times a singular perspective of these within them. But we do need to understand the interconnection. So, for example, the idea of, drug and alcohol abuse or use and like the need for treatment, who has access to treatment, who doesn't, what type of treatment exists. But then we also need to look at the overall kind of societal expectations on what is appropriate, what isn't appropriate, right? And how does that exist within what is healthy and what's not healthy? Disability and like medical supports, for example, right? There's the social model of disability, which I'll get into a little bit later. But then there's also the element that some folks actually need medical treatment for their disabilities. So that again, hence why you would find it in health, but we also need to differentiate it as its own subfield. And so there are a lot of different disparities and how those disparities are experienced by different people. That is where we're going to be looking at the sociology of health, are the way that health disparities are experienced, and how a lot of experiences are minimized in society. So when we're looking at the sociology of health, we have to look at a wide range of things, and sociology studies as well as medical studies, and psychological studies, like a lot of different studies in different fields have noticed a relationship between different, what's called the social determinants of health. Um, and there is a disparity, a huge gap between life expectancy and health quality, across genders, race, and socioeconomic status, disability. And one of the biggest things that we can see, for example, is that folks who are born in lower socio, not born in, sorry, folks that are in lower socioeconomic status, they tend to experience an earlier death. Again, that does not mean that's everybody, right? We're talking about this sociologically, so we're looking at patterns and trends, right, on collective levels. Um, and there's a lot of reasons for that, right? It's access to healthcare, it's access to good doctors, it's access to healthy food. So, for example, one thing to think about are the role of food deserts. So, if you're not familiar with what a food desert is, a food desert is basically a neighborhood or a community that does not have access to healthy, fresh fruits and vegetables, through like grocery stores and such within a certain range, and which means that it minimizes the access to that, especially if you have to walk or you don't have, you have to use public transportation, where you can't, bring that home as easily. So thinking about the relationship between socioeconomic status and life expectancy is crucial. Um, Folks that are in a lower socioeconomic status tend to have greater health issues across our lifespan. Again, different factors. Now, it's important that we note that when we're looking at these things, especially like the relationship between race, for instance, that we're not saying that the individuals of this race are making poor choices. There's a lot of factors that play a role into it. So thinking about like greater health issues across lifespan, you might, if you are in a lower socioeconomic status, you might have to have a more hazardous job. You might not have access to good health care because your job doesn't offer it or it's incredibly expensive. And then also access to, quality institutions that are around within a certain vicinity of where you live. So we have to look at the social divisions and the psychosocial determinants within this. When we're looking at the sociology of health, we're also looking at the social construction of disability, illness, and disease. Um, and this is where some folks kind of conflate and get them confused because they're like, well, I have physical pain and I have actual like physiological responses. Yes, no one's denying that when we're looking at the social construction. What we're looking at within the social construction of like disability, for instance, is how disability is also an identity and how the misconceptions around disability influence the social navigation of the world. So we have to think about how different foods and different and like access to these things play a role in the current conditions as well as the long-standing conditions. Um, and we can see that one of the biggest factors in the health disparities is this idea of material deprivation. So, material items and objects, right? Literally not having access to food and not having access to money. But then we also know that there's biases in the healthcare system. And that's important to look at as well, when we're looking at the disparities. I will cover a couple disparities and experiences as we kind of move forward. So, looking at this is what we understand and what we analyze within sociology and a sociology of health. So when we're looking at the social determinants, right, like literally in the word are social determinants. So the social conditions that determine the type of um, health that you're experiencing. Your experience. Of course, there are some things that are beyond our control. If we're born into it or we were born with a condition, but the social determinants have a lot to do more with what social factors play a role in the types of treatment we receive or the care that we receive. And when we're looking at this from a sociological perspective, we really have to develop an intersectional analysis, right? So that and understand that social identities do tie into these social determinants, right? The social determinants are that they are social identities and conditions that contribute to our outcomes. So some examples, for instance, is we know that Black women experience higher mortality rates during childbirth. This is not, and these studies have been done time and time again, and this is not because of their bodies, nor is it because of their own care, that they like care for themselves. It's because of the level of dismissal within the hospital rooms, as well as other factors that are dismissed, as in different needs that Black women may have. And the fact that a lot of studies have historically always been done on white men and or white patients. So Black women experience far higher mortality rates, to the point that there are some programs out there that actually offer Black patients, and pregnant, Black, excuse me, pregnant Black folks who are um, looking to get a midwife, for instance, uh, free of charge to help reduce the risk of mortality in the delivery room. And that has a lot to do with misogyny. It has a lot to do with obviously anti-Blackness and racism within our society. It's crucial that we recognize this. Black women have also been denied painkillers and medication in many instances because of biases around the assumption of drug seeking, or there used to be, and some people still unfortunately believe this idea that Black women had a naturally higher pain tolerance, so in turn wouldn't need it. And so thinking about that, right, is we can see that this medical system, which is supposed to be rooted in quote unquote science, still has these social determinants and these biases. We see that women overall do experience higher rates of disbelief. So there's a lot of like, oh, you're being hysterical. A lot of women go undiagnosed. And now let me make it very clear that this is not to say that men and are cannot experience these types of things. We know that they can, but we're again sociologically looking at it collectively and as patterns and trends. It's important that we see that this is where those disparities are when we're looking at the patterns. And so women experience higher rates of disbelief in the healthcare system around a lot of things, and that ends up causing long-term problems. Just as like as a somewhat quick anecdote, and I bring this up because we should care a lot about this, because it may impact us, it may impact our family members, it may impact the folks that we're interacting with in our jobs. Several years ago I went to the emergency room with a migraine that felt really different, and I've had migraines since I was 4. And I told the doctor, and the doctor dismissed me and said, it's just a migraine. I said, there's something off. I've literally never been to the emergency room with a migraine before, and this is different. And she kept putting me off, and I said, can I please have a scan? Because my grandmother died from a ruptured aneurysm. My mom had an aneurysm. My aunt has a disorder, a disease called moya moya. And my uncle had an aneurysm. Can you please do a scan? She said, sure, sure, sure. Sends me, does my scan, comes back, says, congratulations, it's clean, you're good, go, sends me home. I get home, I get a phone call about an hour and a half later, and it's the emergency room calling me back. And they called me back, and I went there, and lo and behold, I had an aneurysm. And come to find out, the aneurysm that I had is due to a genetic mutation, which is for a disease called moya moya, which is what my aunt has. It affects mostly folks who are Korean and Japanese, or the genetic one that I have is my grandmother was Korean, and so that's where I received that from, because my grandmother's aneurysm was due to moya moya, and despite all of these factors, despite me giving my history, this resident had told me to go ahead and just go home, and because she had done this, looked at my scans by herself apparently. And so I share this experience though because understanding these disparities, right? That's just one story, but that is one story of a larger collective of disparities, right? We can see that these disparities do absolutely exist. And sometimes when we get into these numbers and the collective, we lose track a little bit of the human side of it. Like we know that there are humans, right? But having these stories, really helps us be equipped with the knowledge and helps us advocate for ourselves and advocate for our friends and our family. And I have just one last quick anecdote. I have my kids' godmother, she's Puerto Rican, and she'd been having some health conditions, including specifically falling. She's older, so she's an older woman of color. And her doctor dismissed her consistently, telling her that she just needed physical therapy. Then she was also dismissed, being told that she simply had dementia, simply. And so, we've been trying to find out what's wrong. It's not she also had another neurological condition. And so we can see, right, like these stories are not just simply anecdotes, they are a part of that larger collective. So this is where those social determinants play a role in how people are navigating these systems and why it's important we look at them sociologically. Um, On that note, disabled individuals are normally brushed under the carpet too. So, for example, if a person has fibromyalgia and they present with some sort of like chronic pain, it may simply be dismissed just as their fibromyalgia flaring up. And it might be, but it could also be something else going on. So, we can see that disabled people are also swept under the carpet. And brushed off to the side. And we'll talk a little bit about the theoretical components of that too. Um, Predisposition and epigenetics play a role. And I say that because it has a lot to do with stress environmental factors. So epigenetics, I'm not a geneticist and that is not my background, but the quickest kind of understanding of epigenetics that I can explain is that yes, we all have some sort of like genetic predisposition to things to some extent, or not all of us, but many of us do, and predispositions do exist. And predispositions are essentially where you have a higher chance of developing something. Now, epigenetics play a role in this though, because epigenetics recognize that there are social factors and environmental factors that contribute to the genetic changes in our bodies. So, for instance, my genetic mutation of moya moya, I have that gene for moya moya, which is why I had the aneurysm. That was not something that was just like a personal failing or my grandmother's. There is some theoretical work out there that has looked at the role of, for example, occupation of Korea and how that might play a role in the development of that. So that, for example, could be one contribution, right? The epigenetics are those social factors that change our it could be food, it could be stress, it could be the environment and how those play a role in our genetic changes as a larger people and as individuals. Another example is that we also can see that there are higher rates of asthma that correlate with redlined neighborhoods. So neighborhoods that were historically redlined. If you had a map of like where most of the asthma is concentrated in a city, and you had their redlined map, you can see that there's an overlap between the areas that have higher rates of asthma and being redlined. This is true of San Diego. There are higher rates of asthma, for example, in National City, and that's, has a lot to do with the type of air quality because of the exploitation of the environment, and there has a lot to do with like the way that neighborhoods were lined at the time. So we can see that these are all some social determinants and factors that play a role in that. um so thinking so I want to wrap up the kind of overall idea of health and go into now a little bit more of the kind of drugs and alcohol. Before I do, I want to kind of wrap up some thoughts with why that's important. So, when we're thinking about the role of health in our everyday life, right, we have to also see about what we have access to, how health plays a role in what we have access to, but then also the way that neoliberalism and capitalism and our socioeconomic conditions contribute to us feeling like humans or feeling dehumanized. And I say that because a lot of what we're going to talk about in the drug aspects have to do with alienation, and alienation kind of in that Marxist sense being that we're alienated from each other and we're alienated from the work we're doing and we're alienated from ourselves, right? There's kind of these like multiple layers of alienation going on. And if we think about the sociology of health, right, and how we might be alienated from, you know, each other, right, then it's really easy to dehumanize people when you're navigating the healthcare system as somebody in a position of power. Um, and we'll see that within disability too, because it's crucial again that we look at how to critically analyze these things. When it comes to drugs and alcohol, I want us to think about again who has access to treatment. How do we define what drug use and abuse is, and what are our biases around them? So we're going to transition into drugs and alcohol now and understand what the sociological perspectives are. So the sociological definition of a drug is a chemical substances that have direct effect on the user's physical, psychological, and or mental functioning. It also has a potential to be abused, and it has adverse consequences for the individual and society. So, for example, loss of productivity, loss of socioeconomic conditions. It might cause a detriment to the neighborhood. So, in San Diego, before I get further into this, I do want to say that this section may or may not be triggering to some people if you have had some sort of substance dependency or abuse. So I just want to give you as a warning that this may activate some feelings or discomfort for you. Okay, so for example, San Diego, specifically Claremont. So if you're not from San Diego, Claremont is the largest suburb in the city. I went to high school in Claremont, and Claremont was being absolutely decimated by methamphetamine use back in like late 1990s to probably right around 2008, 2010. That does not mean it's still not being used, but it has switched and transitioned. So methamphetamine use was very heavy. It had one of the highest rates of methamphetamine use in the world in Claremont. And so that is one example of how, why that would be a drug is it has an adverse consequence. The neighborhoods were being decimated and it was doing direct impact to the schools as well as access to those drugs inside the schools. So that is the sociological definition of a drug. Now, drug abuse is essentially where the standards for drug use are violated. So, for example, if it is cannabis 25 years ago, right? Cannabis used 25 years ago was if you use it, you're not talking about it. Or cocaine use, right? It's illegal. So, any use of that could technically be drug abuse. Essentially, it's if there are social standards for drug use, then in turn, any violation of that use is considered essentially drug abuse. Now, it's different than drug addiction. A drug addiction is a dependency. It's a chemical dependency in a physiological and or psychological sense. The drug becomes something that's compulsive and you need, right? You need to have it. This is why, for example, if you think about caffeine, caffeine is considered a drug, right? Because it does alter mental functioning. It has the potential to be abused and used, especially if you're drinking it far more. And it could have consequences, right? Sociologically, I would say though that we wouldn't consider caffeine quite a drug, but that's why medically and other areas they do consider caffeine a drug. Is why it's also not allowed to be used in certain areas. And so when we talk about the cultural role of it, this is another component that I'll talk about in a little bit. So for example, if you are Mormon, right, consumption of caffeine is a no-no, because it is viewed as some sort of mind altering substance. But that's also why caffeine can be considered an addiction. And it could because it is a chemical dependency upon it to help us functioning. And there are people who are, it's like the idea like I can't live without my coffee. But now the adverse consequences of that are far different than, methamphetamine use, for example, in society. So drug addiction is a chemical dependency on it, and in a way that it becomes compulsive. And this is why the idea of treatment for drugs and alcohol are important, and this is why alcohol is considered a drug as well, because it has all of these elements tied into it. But when we start thinking about the role of drugs in our society, and we think about how we define it and what is and isn't appropriate, we do need to consider the norms and narratives around it. Who's receiving treatment again? Who's receiving what types of consequences? And how our social norms um, play a role in that. And to be upfront now, I will be explaining more around like consequences when we talk about criminal justice, the criminal justice system, because that's where we're going to really dive into that more. But it is also important that we overlap it with the current times, the current topic as well. Um, so structural functionalism, when it's looking at drugs and alcohol, looks at how drug abuse in itself is a response to the weakening of norms. So Durkheim talks about anomie, and anomie being a lot of folks will explain anomie as a sense of normlessness, but it really has to do with a sense of like no singular set of norms. And if we look at this and it's essentially a state of chaos. So that's one structural functionalist perspective at looking at why drug abuse would exist, is that it's a response to this weakening of norms. We're in a state of anomie now. One example would be from the 1830s to the 1960s, where we see this rapid change and this huge shift from like the agrarian culture to urban life and this huge shift within our civilization, this rapid social change and stress, then there's this huge spike in alcohol consumption, though. And so that is one way to look at the role of drug abuse from a functionalist perspective, right? There's this inconsistency in norms, these constant changes. Another way with an anomie that we could look at it is how there again this inconsistency of norms. So, for example, we know that there are dangers of drinking and smoking, and yet there are advertisements both for them and against them, right? So there we don't receive any singular perspective of norms, and instead, what's happening is that this inconsistency can contribute to use and abuse of it. Furthermore, this idea of feelings of isolation and estrangement and alienation can contribute too. Now, conflict theorists and functionalists would look at both of those, but from a structural functionalist perspective, right, we're missing that cohesiveness and that community. So, in turn, that is what would contribute to this idea of it, right? We don't have a community and a sense of fulfillment. And so, in turn, that would contribute to the drug abuse because of this disconnect. The next code word is rope. The next code word is rope, R-O-P-E, rope. Okay, so going into conflict theory we know looks at the differentials, like power differentials and inequalities between people. And when we're looking at drug use and abuse, it's important that we see how um, this differential can influence not just drug behavior and societal values, but going back to the idea of like, the criminal justice system and who receives what type of experiences. But regardless, conflict theory does heavily look at, though, the role of capitalism and alienation in it. So, yes, while the first one, while structural functionalism does look at alienation and isolation, they look at it from a different perspective of community, while conflict theorists are looking at the overconsumption and drug and the abuse of drugs in response to capitalism because we have this deep sense of alienation due to this socioeconomic conditions. So for example, this idea of drinking after a hard day's work, right? Happy hour is right after work, right after your 9 to 5 job. And so that's where happy hour is. And it responds to this alienation of capitalism, this alienation from ourselves, this alienation from our work. And it's essentially, it's a response to, right? This drug abuse or drug use in general, and behaviors become a response to capitalism. But again, that violation of norms, right? So if happy hour wasn't the norm, but you were still using it, right? That becomes a matter of drug abuse versus it being just, recreational use. We also have to look at those in power around drug use, legality, and appropriateness. So I want to bring up the role of imperialism and white supremacy because of the fact that mind altering drugs in themselves might have cultural significance to certain groups. Um, so, for example, like peyote, right? That may have cultural significance to people, but white supremacy plays a role in the conviction of it or the perspectives of it. We also have to look at how. So, for example, like white supremacy, not just cultural differences, but also white supremacy in terms of when is it legal for who and when is it not. So crack versus cocaine, for example. Crack is often used by BIPOC folks, so Black, Indigenous people of color. It has been historically predominantly placed in and used in African American and Black neighborhoods. And meanwhile, cocaine is often used by rich white folks. And the sentencing is significantly different. Um, 5 grams of crack has the same sentencing as 500, well, at least historically. 5 grams of crack would have the same sentence as 500 grams of cocaine, for example, right? So looking at that sentencing, that in itself highlights this kind of role of white supremacy and the social perspectives of this, right? So it is an intentional targeting of lower income people and Black people. Meanwhile, those who are in positions of power, those who have money, and those who are white often are not receiving the same sentencing. And so we can see how that social class dynamic is important. Alcohol, for example, right? Alcohol is still very heavily socially appropriate. Meanwhile, cannabis was not and is still not federally. And we can see that they do provide and present with different struggles, and yet there are very few restrictions on alcohol. Um, Opium use was heavily used in the 1800s. Um, we saw that in the 1800s, when you had Chinese people working on the railroads in the United States, it was being used. But as white unemployment increased, then suddenly opium was no longer legal. So opium then became illegal as a way to criminalize Chinese people and to prevent this supposedly prevent this idea of employment. It was very much using them as scapegoats. So opium use was legal, then it was not, when suddenly we see that white unemployment is now increasing. Uh, Cannabis is another example. So the 1940s penalties were great, were greatly, they were huge, especially when you saw that cannabis was not being used quite as much by white middle and upper class people. But then when college students began using it, white college students began using it, the penalties became suddenly decreased significantly. So we can see how the conflict theorist perspective can look at this in a couple different perspectives. One being this alienation, right? We are detached, so we might have this drug abuse and use, but then the other also being the social construction of drug abuse and use. It is still drug abuse if it's legal, right? And you're using it even recreationally and mildly, because you're violating those norms. So the conflict theorist perspective allows us to see that and help us push against that to have a critical perspective. These are all facts. These are not things that are made up, right? And unfortunately, some people think that this is all feelings based, but these are facts that highlight, right, that racism absolutely has and does exist within our systems. And when we're looking at the sociology of alcohol and drugs, we can't deny that. Um, Okay. And then symbolic interactionism is the other perspective where drug experience definitions and expectations kind of are guided by our social conditions in the world. So thinking back again, what I said about culturally, right? Some cultures, it may have a very sacred, certain drugs may have very important and sacred meanings to them. And excuse me, so that's one example. Another is that individuals are taught the experience, so they have to be taught that it's pleasurable or not. The experience kind of guides how we may navigate that. Norms around use as well. So, like what is appropriate to smoke or to drink or to consume, whatever that might be, right? Those are all important norms to develop, and symbolic interactionists look at that. Learning those motivations and approaches through small groups. Our experiences also are important. So, just as another anecdote, for example, like my mother had a drug addiction, and I never touched anything when I was growing up, or I just never touched anything because I had no desire to. So my lived experiences taught me the negative side of it. That influenced my perspective, but somebody may have a completely different experience to navigate that. And that's what symbolic interactionism is looking at, right? Is the symbols and the meanings that we've developed and the relationships we developed toward it. Howard Becker did a study called Being a Marijuana User in the 1960s. And in there, it was about being taught how to use cannabis with the what's and the whys. And he did this study where he literally was looking at, how people inhale, how people learn to hold it, how they learn how to grip a joint. All of these things were really important in Becker's stuff because it highlighted that there are cultural norms with it. And these cultural norms and learning the norms are one of the only ways to really kind of help with the continued experience of smoking it and of being a part of the group. So symbolic interactionism does play a significant role in understanding the cultural norms and the symbols that we develop and understand through them. Okay, so we're going to transition now into the sociology of disability. And these memes here are some examples of what's called that Stella Young in the video that you're supposed to watch explains as inspiration porn. And that inspiration porn is essentially the idea of objectifying. She says it's very intentional, she calls it that, because it's the idea of objectifying a group of people. These all seem like they're well intentioned and sweet memes, right? But it's still using disabled people as a form of motivation. And it's really, I do, if you haven't watched that video, I really would like you to watch it. It's important and it's crucial that you do. And in here, the reason that we see this is that the idea is that disability is now used as somebody's tool to be motivated, right? And it also denies the social model of disability. So the social model of disability is recognizing that social conditions are there and that influences the way that we navigate the world if we're disabled. Um, so one of the things that Stella Young talks about is that no amount of a good attitude will turn a set of stairs into a ramp for a wheelchair user, for instance, right? So that's just one example, right? The world is designed oftentimes for able-bodied, non-disabled people to navigate. And for example, the corners, the walkways, like when you're crossing the street, if you've never noticed, a lot of them have yellow bumpy declines, but those corners were not there prior to the 1980s. And so, and 90s, and and as we see them now, that's actually relatively new. So no amount of a good attitude, no amount of positivity, no amount of growth mindset, no amount of any of this stuff are going to change the social conditions that are designed for non-disabled people, right? Um, and so that's what we're going to be kind of talking about is this difference between the medical model and the social model of disability, and how we can analyze those sociologically. So when we're talking about disability, um, it's essentially anything that deviates from quote unquote normative abilities. It is important that we try to avoid using the language around, oh, we're all a little autistic, we're all a little ADHD, we're all a little whatever, because that's not true. The idea of normative abilities do dictate and determine how to navigate these things. And that's where the idea of disability comes in. And that's where the social model of disability comes in, is that it's not necessarily your body doing a disservice to you. It's that social structures and systems haven't been designed to help support you. That does not mean that when we're talking about like physiological responses, that a social model of disability is going to somehow solve that. That's not what the social model is recognizing. It does push us to question, why aren't there more accommodations and supports in that case? So, what is disability? It's anything that deviates from normative abilities. There's different types of disability. So you have physical disabilities that could be like around your mobility, so movement. It could be physiological, right? So your chemical reactions and biological reactions. Could have chronic, where it's ongoing and constant, or fluctuating, where some days are great and some days aren't. You can have a visual disability, hearing disability, mental disability, intellectual disability, and learning disability. It is important to note as well, because I know I say that a lot, and that's because they're all important to note, that a lot of folks who are deaf and in the deaf community do not consider themselves disabled. That does not mean there are not exceptions to the rule, but that's important to recognize, because that is a cultural value within their cultural group, right, and community. And so that's important that we understand that and recognize that and believe that, and honor that, right? Because the idea of what it means to be disabled is a part of our society, but we also have to understand how groups identify and how their navigation of the world shapes that. So, the sociology of disability was often situated under medical sociology or sociology of health. And I think that we really need to expand beyond this. When I started first lecturing on the sociology of disability, I couldn't find really much of anything that was in, especially in a textbook, that talked about disability. And when we talk about it, I think that we really need to pull from disabled researchers and experiences, though. So, disability is socially constructed because we have to ask ourselves, what does it mean to be normal? Right? It doesn't mean, again, that different experiences are invalid or that we should dismiss them, but rather we have to look at, somebody's existence and how they navigate the world if their abilities are not quote unquote normative. We think about the role of deviance too. So deviance is essentially anything that violates social norms. So there is a strong connection, right, between disability and deviance, because if you are existing as yourself authentically, wholeheartedly who you are, and you show up as your disabled self if you're disabled, right, that can be seen as a form of deviance because that violates the social norm and the functionalist perspective of what we should strive to be. Um, and I really want to ask this question, like, you don't have to answer it here or anything, but I want to ask you, like, do you consider disability when you think about greater society, when you think about social change, when you think about social norms? Are you considering how disability can be represented? And that doesn't mean just accommodations, right? Accommodations are important, they're crucial, but we have to go beyond just accommodations. Accommodations recognize that the system and structure are not in place for everybody. And so do you think about how disability is often dismissed but still impacts everybody across different cultural and social values and identities? So some perspectives of disability is that for the United States relies on this idea of reification, is that disability is in itself real and it's just a part of the individual. I am not denying that disability is real, and I am not denying that there are some disabled people who you know have real physiological responses. Again, this is that the United States is essentially saying, like, the United States perspective of reification is that disability is real. And in turn, because it's real, there's nothing we can really do except just kind of support people, right? There isn't a huge issue with our system or structure. It's not socially constructed. And because if you deny that it's socially constructed, then that means that you can deny any of the social changes that you can make to reconstruct that. Um, Meanwhile, some others do use social constructionism, and we are making some progress within the United States too. But the social constructionism is the idea that disability is a phenomenon because of society's expectations. The cultural view will determine what is a deficit, so what is lacking or what's not. A lot of special education. So I've been a K-12 classroom teacher, and I have a son who has an IEP, an individualized education plan. A lot of the language around that is deficit. The student has a deficit in this, a deficit in this, a deficit in this. What is lacking? But the argument about what a deficit is actually situated within the context of society's expectations. I'm not going to get into all of these, but these are just some studies that have shown the different views that people have around disability and what families and folks have. But one of the biggest issues with a lot of these studies, though there is a shift going on, is that a lot of them come from the parents and caretakers of disabled folks and actually are not coming from disabled individuals themselves. I will use disabled more often than not, um, because of the social model, right? Recognizing that it's a social identity, just like I will use the term autistic, because not majority, the autistic community prefers the term autistic, recognizing it's a social identity. However, if somebody who was disabled or identified as somebody with a disability, or somebody who was autistic identified as somebody with autism, I would honor that identification as well. So as when I'm talking about things like being disabled and autistic as examples, I am referring to it as a collective, as individuals. So just to kind of note that. But regardless, the studies are lacking a lot from the perspectives of those who are most influenced and impacted. So going to the social model, again, is that the medical model is the dominant perspective still. It's the recognition that that experience should be viewed medicalized, right? So that's one of the reasons why the autistic community prefers to say autistic and not with autism, because with autism tends to medicalize it. Um, there has been a small push of using language like identified as autistic or identified with ADHD as opposed to diagnosed with, because again, kind of trying to move from the medical model. That does not mean that there are not medical implications for people, nor that there are overlaps of other medical conditions. Nonetheless, I think it's important that we know that even those overlaps, right, are not necessarily directly related to those identifications. So the medical model looks at them as purely medical conditions, versus the social model is that society has not adapted. These systems and structures have created obstacles for people that are disabled or have disabilities, and it makes it significantly harder to navigate them. The social model, again, does not dismiss real physiological experiences and risks. So, for example, my brain aneurysm, the social model is not dismissing that I had a very real threat in my brain, right, with an aneurysm, or that my mother did. What the social model is doing is recognizing that these systems and structures have made it harder for me, and so I had accommodations, for instance, in my PhD program, and that the social conditions have made it harder for my Asian grandmother, for example, to have sought help and actually received help before it killed her. So these are things, right? This is what we're looking at when we're thinking about the social model of disability. Um, the next code word is hat. The next code word is hat. Okay, so I'm going to wrap up with the kind of theoretical perspectives around disability. So as I mentioned, structural functionalism is the dominant lens in our society. It really is. It also tends to look at disability more often than not from a temporary space, and it medicalizes it. That does not mean that functionalists deny that there are some people who will be disabled for the rest of their lives, but rather that people should constantly strive to get better. Um, Parsons said that, and so I had mentioned that I was getting more into this around disability. Parsons explained that the disabled should have to play the sick role, right? They have to play the sick role in order to receive care. And when I talked about disparities around health, that's kind of one example, right? So if you don't present as sick enough or in pain enough or whatever it might be, you're not playing the role enough. And Parsons argues that this is really kind of what's required for care. Unfortunately, it creates this hierarchy between doctor and patient, um, which from a functionist perspective, that would be natural because doctors are the ones who are experts in the field. And while I'm not denying that, right, I respect their training. I recognize their training. It also tends to remove any expertise on our own individual bodies. And it tends to create this dichotomy where as patients it's almost, you are unheard. Impaired in this case from a functionalist perspective is more of a permanent level, and that impairment oftentimes removes the human status. A lot of the reason for this is because structural functionalism overlaps a lot with neoliberalism, right? So if you're disabled, you cannot contribute from a functionalist perspective. Let me make that very clear. That's not my personal opinion. Cannot contribute to a capitalistic structure, right? You are not contributing to productivity. And that's because a good health, quote unquote, good health is essential for a functioning society. We're not functioning, we can't fulfill our roles, right? So we should constantly want to get better to contribute to that. That's a functionalist perspective. Um, Meanwhile, conflict theorists look at this the relationship between power and resources. So, social inequality, for example, within money. So it is not uncommon for folks who are disabled to receive no more than $800 to $1,100 from the government on their disability check. So people think that if you're on disability, folks who do fully subscribe to the functionalist perspective, there is this narrative that if people are using disability or SSI, that they are mooching off the government. But $800 to $1,100, especially in this economy and in our social structure, is nothing. And that really highlights that. And this relationship between those in power and those are not are very evident, because even if you are on disability, and you're bringing that in and you somehow manage to save money, you can't have more than $2,000 in the bank. Otherwise, they start deducting your money. So it really does perpetuate this constant cycle of poverty within disability. People from a lot of oppressed backgrounds have oftentimes have the poorer health, but they also receive poorer care and treatment. So I was talking about that around social disparities, right? And that's where a lot of that overlap is within disability. Um, Physicians maintain control, so we can see how there's these social problems versus like medical problems within that, right? Physicians have the power to write prescriptions, the power to see you, the power to put a referral in if you have an HMO. Again, understandably, because they are the experts, we can't just necessarily trust everybody to be writing their own prescriptions. But this maintenance of control does also oftentimes mean that there is a control over disabled individuals. Remember, though, that a crucial element of conflict theory is that this critical awareness pushes for revolt. So we have seen a significant number of disability movements in our society, disability rights movement. There was a young person who was a wheelchair user who climbed the steps, and that's a pretty powerful clip during the 1990s disability rights movement. But we really do need to see this relationship between individuals and society, how they're viewed, how they're supported or not supported, right? And the these kind of perpetuation of poverty for those who are disabled. Meanwhile, symbolic interactionism is looking at the social construction, so there's no objective reality. This perspective has received a lot of criticism, and I get it. But I think that a lot of it is rooted in kind of a misconception of the theory, as well as the theory kind of not fully having a full fleshed out idea of it because of a lack of disabled voices. Before I get into the rest of this, your last code word is basil. So the last code word is basil. But it's really, even though I said the last code word, just bear with me here. So ADHD, for example, I have ADHD. I am not denying, it took me till I was 32 to get diagnosed. I am not denying that exists. My daughter has ADHD too. Not denying that exists. Let me make that very, very clear. But a symbolic interactionist perspective does look at how we label and define things. So ADHD, for example, was not something that was identified until Ritalin was starting to become gain a larger following and introduced to the market larger. That does not mean that ADHD did not exist before. What it does mean is that there's more awareness, just like the narrative, like, oh, autism didn't exist 20 years ago, 30 years ago. No, that's baloney. It absolutely did, right? But we didn't have the language and the social constructions to really start articulating it in the same extent. First off, it was already identified before then. It had already been in published articles by then. But that narrative, though, does show how there's this disconnect between a recognition of the symbolic meanings and the social construction of these things and the language to identify them. There, and when I say, for instance, the autistic community does not see a need for medicalization. That does not mean that there's a dismissal of a need for certain medicalized things, right? Like medication, but rather that being autistic in and of itself should not be medicalized. That's what that means. There's a look at interactions between patients and healthcare professionals as well from a symbolic interactionist perspective. So going back to that idea of authority, so the white coat being significant, the stethoscope being significant, right? We attach certain meanings to it. Even the idea of a doctor. So a lot of folks, for instance, who don't quite understand the history of it, think that people with PhDs, like myself, and many of your professors, should not be called doctor because we're not medical doctors, but PhDs actually were using the term doctor before medical doctors were. So this kind of narrative around what it means to be a doctor is also important. And we can't pretend that there are not real social inequalities and that people don't have real serious health risks involved with certain conditions. Okay, so that's kind of all I have for this for now, just to kind of think about all of these factors again. Just kind of wanted to provide some foundational concepts for you as you read the readings and the articles and you move forward and start kind of critically thinking. When you're thinking about when you're thinking about your visual entries as well for this. Some things to think about could be if you see like an elevator that's broken down, or you see a ramp that is shut off or rocky, or you see a classroom that is really not so great. That would not be accessible for a wheelchair user, for example. That's one thing to consider. You can also think about DARE. If you see, like, there are some folks that still canvas outside DARE. DARE has actually shown significant DARE, the program for drugs, has not made any things and actually has contributed negatively to drug use. So you might do something like that, or maybe you take a photo of something that recognizes health disparities, whatever it might be. Right? Remember, these are things to think about, to kind of think about critically as you're thinking about how to weave together this lecture as well as all of the other elements of this week's modules.